All right, everyone. We are going to get started in a second. I'm just waiting for a couple people. I see people joining, but I would like to welcome you to our panel today, where we'll be talking about health literacy and engaged decision-making across the cancer care continuum. And so we have our speakers with us today. We will start with Dr. Ashley Houston, who's going to talk about screening, then Dr. Tamara Cadet, who will talk about screening cessation, then on to Dr. Aisha Langford, who will talk about communication in cancer clinical trials, and then finally end with Katrina Ellis, Dr. Katrina Ellis, who will talk about family-focused care and treatment and beyond. And then we'll save some time for some panel discussion at the end. So welcome everyone. I'm going to start by introducing our first speaker, Dr. Ashley Houston, who will talk about Project Insight, exploring breast cancer screening initiation intentions among racially and ethnically diverse women in their 40s. Dr. Houston is an assistant professor of surgery at Washington University School of Medicine in St. Louis. Dr. Houston's research focuses on supporting cancer screening and treatment decision-making to reduce health disparities and address challenges associated with health literacy in diverse populations. Specifically, she's interested in the dissemination and implementation of decision support strategies to improve health behaviors and outcomes, particularly in populations that experience cancer-related health inequity. So I'm going to invite Dr. Houston to take the floor.
Thanks, Christine. Thanks so much. I appreciate the opportunity to present here today. I'm just sharing my screen with you all now. Hopefully you can see it in presentation mode. Set. All right. Well, thank you so much for the kind introduction. And as Christine said, the title of my project is Project Insight, exploring breast cancer screening initiation intentions among racially and ethnically diverse women in their 40s. And I just wanted to start off this presentation, this discussion, talking a little bit about why we're still talking about breast cancer screening recommendations for women in their 40s. So there's still a lot of debate and contention around initiation and frequency of breast cancer screening for women in their 40s in the United States. So one example is an article that was published in JAMA Internal Medicine just this past March. And they did a review of NCI designated cancer centers and found that over 80% recommended women be screened annually and starting at age 40. And this is in contrast to the US Preventive Services Task Force, which recommends women start at age 50 and be screened every other year. So this was definitely a splash, made it in the New York Times. And another group of articles that came out just a couple of weeks ago, talking about equitable screening mammography strategies for Black women in the United States using simulation modeling. And this group found that for Black women who started breast cancer screening 10 years earlier, it would reduce some of the mortality-related disparities that we're seeing by 57% between Black and white women. But there are also a lot of complications that come along with this. So in a companion editorial, Dr. Jones outlined a lot of the issues with using race-based categories, socially constructed categories to identify these different strategies for screening at the population level, and how this might overlook some of the other barriers, racism that we're seeing in society, and kind of overshadow some of the approaches for addressing some of these disparities. So I just wanted to kind of set the scene, paint the picture for what this looks like for breast cancer screening for women in their 40s in the US today. So talking a little bit about health literacy and thinking about health literacy in the context of cancer screening. So we know that health literacy is a strong predictor of a variety of health outcomes. And this includes those with limited health literacy and often engage in less preventive care, which includes cancer screening. And so when we think about cancer screening and ways that we can develop interventions, one of the strategies, an evidence-based strategy that's been used, is shared decision-making. And this is in the context of using a patient decision aid for a shared decision-making conversation. And this improves knowledge for patients. It improves participation and communication in the decision-making process. However, we do know that equity is needed in a lot of these decision support interventions, particularly when developing patient decision aids and testing them. So there is a need. Very few patient decision aids have been tested and used among socially marginalized groups. So there is a need for equity in this development. And so when we're talking about benefits and harms of cancer screening, I often find that it's a little bit difficult to kind of conceptualize, well, what are the harms associated with cancer screening? We focus so much on benefits. And so Harris and colleagues developed this taxonomy across 4 different domains: the physical, psychological, financial, and opportunity costs associated with the benefits and harms of cancer screening. So thinking about some of the benefits, things that we've often heard: the potential for early treatment, early detection, increased chance for cure. And then some of the harms that are associated are additional testing, invasive tests, false positives, the potential for overdiagnosis, and then some of the financial concerns as well. So while screening is often covered by insurance in the United States, harms or costs of additional testing, diagnostic testing, are often covered at a different rate. So really thinking about some of these benefits and harms as we're discussing cancer screening, and in this context, breast cancer screening. And I mentioned a little bit of the contention around breast cancer guidelines for when to initiate and the frequency of screening. And so there are a variety of guideline granting agencies in the United States, and 3 of them, NCCN, ACS, and the USPSTF, they provide recommendations for initiating breast cancer screening starting at 40, 45, 50, and the importance of using shared decision-making when making a decision to initiate in your 40s. And then there's also differing recommendations for whether that's yearly screening or screening every other year. So I just wanted to present this to you all to get a sense of what we're kind of trying to show here as women are making this decision. So for this presentation, I'll be focusing on Project Insight, and the purpose of this project was to examine the knowledge, attitudes, and intentions of racially and ethnically diverse women related to divergent screening recommendations for breast cancer screening mammography in the United States. And for AIM-1, we conducted focus groups and a qualitative analysis to assess patient or participant attitudes, knowledge, and intentions. And so we recruited women 40 to 75 years of age, but for this presentation, I'll be focused on the women who are 40 to 49 years. And we recruited both Spanish and English-speaking women, Black, non-Latino white, and Latino women with no known increased risk for breast cancer. So I do want to highlight that too. The guidelines that I had just presented, those are all for women at average risk, no known increased risk for breast cancer. And we conducted focus groups, and in our focus groups, we had 2 educational presentations covering mammography, guidelines, and benefits and harms. And then we had pre and post questionnaires for knowledge, attitudes, and intentions. And we also assessed health literacy and numeracy and collected sociodemographic characteristics. So just briefly, we had 134 participants total, and 52 of those were women aged 40 to 49 years. And we had roughly equal numbers of participants across race and ethnicity. About a third had limited health literacy, and fewer had limited numeracy. So getting into the results, and this is just a really brief presentation of the results, but I wanted to highlight some of our key findings about questioning the recommendations. So there was a concern about the quality of evidence for these recommendations, and some of our participants expressed that they really don't have good information, that they're not using good data to develop these types of recommendations. There were also questions around the lack of representation of racially and ethnically diverse women, not only in the data set used to develop the recommendation, but also among the recommendation granting agencies, if there was enough representation of women and also of racial and ethnic diversity on those panels. And then there was also interest in a consistent recommendation. So having organizations potentially come together and come up with a more streamlined recommendation, because these divergent recommendations really led our participants to question all of the recommendations even more. So with those findings, we took our focus group findings and used them to inform our user-centered design for developing a decision aid. And this user-centered design engaged our stakeholder advisory group, and we used a lot of the feedback from the focus groups and stakeholder advisory group to develop a prototype. Went through some cognitive testing and refined that design multiple times, going back through cognitive testing. And we did 3 full rounds of cognitive testing, but we did some edits to the design and refining the language with our stakeholder advisory group multiple times. So just giving you a little bit more background about our stakeholder advisory board, we had 2 clinicians and 2 community members. So it was a small group, but it was a small but really engaged group. We met every other month, and we are continuing to meet actually as we're going through the analysis and writing up of results and dissemination of results back into the community. But this group was really engaged, and the clinicians provided that clinical perspective, and our community members were breast cancer. One was a breast cancer survivor, one a breast navigator. So really engaged and kind of know the community well. We also worked with the Breast Cancer Community Partnership, BCAP. So this is a group that meets monthly. They're made up of breast cancer patients, survivors, navigators, clinicians, a lot of them working at the community level. So we presented some of our work to them and got feedback throughout this process as well. And we also partnered with Health Literacy Media. They incorporate health literacy into their content and design, and we worked very closely with them as we were developing and testing our prototypes. So I just want to present some of the process of some of the kind of messy process that we went through at the beginning to kind of get to the current iteration, which we're testing right now. So as I had mentioned before in our findings, our participants really wanted to get a sense of how these the data was built, how these recommendations were developed. And so they wanted to have probabilities and information associated with that for presenting the differences of starting in your 40s versus at age 50. So we were a little bit torn on the design side if we wanted to include that, but it was a priority of our stakeholders. So we did include that. We started off with an icon array, got some mixed feedback from stakeholders, went to a more text-based presentation, and then we modified that a little bit more to highlight some of our findings. And this is the final version that we came up with. This is by no means kind of the standard, but we wanted to test this. So we're testing it now. So hopefully next year we'll be able to present some of the findings that we have for testing this presentation of our data here, or of our decision aid here. But we have on the far right column the differences between starting breast cancer screening in your 40s versus age 50. And then one other component that I wanted to highlight in this presentation was the inclusion of narratives. So we had such rich data with our participants in the focus groups, and we wanted to include the participant voice in our decision aid. So we started off with kind of a presentation of narratives on the side of the page, and we changed that to make it look a little bit more conversational. And there was still a lot of concern about the amount of text in the tool, so we refined that design even more, reducing the amount of text, but we still really found that our stakeholders and engaged partners wanted to have that participant voice. So we thought it was worth the trade-off of having some additional words in the tool in order to have that participant voice. So we're now in AIM 3, feasibility testing and preparing for a larger trial. So we just finished online recruitment, and we had participants go to either the intervention arm, which was the decision aid we developed, or control, which is standard breast cancer screening educational material. And we had a post questionnaire for our participants to go through. So results are coming, and we can get a little bit more insight into the presentation of the probabilities that we had presented in our tool. So I just wanted to go over briefly just some of our lessons learned. So really some main takeaways were an interest in the transparency of the source information, even when there are limitations. So even when the data is limited in the presentation of the inclusion of racial and ethnic minorities or other groups, really being transparent in that information. And then also we wanted to highlight that there's an option to make this decision every year. When you're turned 40, it's not like you have to make that decision for the rest of your screening life, but you can kind of make that decision each year with your doctor. And also the importance of using patient voices. So the inclusion of those narratives in our presentation. So thank you so much. Just a little snippet of some of the work that we've been doing in this area, but please feel free to contact me with any questions.
Thank you, Ashley. That was a great talk. I really liked your slide incorporating narratives, and you talked a lot about that. Generally, the use of narratives in decision aids can be controversial, as you know, especially thinking about providing balanced narratives and what role they play in the decision itself. But we know that also some research has shown them to be particularly effective for populations who have more limited health literacy. So how did you weigh these considerations in adding narratives to your decision tool?
That's a great question. And it's something that we really wrestled with because there are such concerns, and it is kind of a controversial area. So oftentimes narratives have been seen and shown to be slightly persuasive for a variety of populations. But as we were incorporating narratives in our design, we really worked hard to ensure that our narratives were much more process focused and experience focused. So trying to reduce that bias that could be introduced when you use kind of an outcome focused narrative. So a narrative that really focuses on, I made this decision, we went through this process, and this was the outcome I had. And those have been found to be slightly more persuasive. So we used narratives that were more process oriented. So what somebody went through in that process, and then the experience. And the experience really helps to improve knowledge, and it provides a little bit more of an emotional component, which has been found to resonate more with those with limited health literacy. So that was the approach that we took, and controversial, but we really thought that the feedback from our stakeholders was important for including those.
Great, thank you so much. So now we're going to move a little bit further along down the cancer care continuum, and I'm going to invite Dr. Tamara Cadet to share her presentation, which is entitled Designing and Testing Decision Aids to Help Older Adults Decide Whether or Not to Continue Cancer Screenings. Dr. Cadet is an associate professor of social policy and practice at the University of Pennsylvania. Her overall research focus is to advance efforts to develop health promotion interventions with underserved and underrepresented populations and communities. Her current work focuses on health disparities of older people, particularly around cancer screening and cancer care. Her work is at the intersection of health and social work, spanning the areas of evidence-based health promotion interventions, facilitators, and barriers to reducing disparities in preventive health behaviors. So Dr. Cadet, I'll have you take the mic.
Afternoon, thank you. I'm delighted to be here to share with you a little bit about what I have been working on and what I continue to be working on. So I think you can see my slideshow from beginning. There, whoops. Okay, let's go back. Okay. It's so interesting to come after Dr. Houston when we talk about cancer screening, because I think we have all been conditioned, a lot of the literature has been conditioned, the older adults that I'll talk about have been conditioned to get screened. And so this idea of why would we stop screening is new for some of them, and yet I think it's worth having a discussion. So I'm delighted to be here. And I just want to acknowledge my mentor, Dr. Mara Schomburg, who's at Beth Israel Deaconess Medical Center in Boston, and the diversity supplement that was part of this work, and then my current K23 out of the National Institute of Aging. So I really wanted to start with this idea of us imagining for a moment. Imagine designing an amazing intervention. It gets funded, patients love it, publications, you have everything, and then you get asked the question, so how does this work with or in diverse populations? Or how does this work with populations who may have more limited low health literacy than others? And in particular, how does this intervention work with older adults? How would you know? And so when we think about some of the cancer screening guidelines, and Dr. Houston went over some of them, so I won't be go in great detail, but when we think about adults, older adults that are older than 75, they're encouraged to engage in shared decision-making around cancer screenings. And in particular, I'll talk about breast and colorectal cancer screening. And that's because of the uncertain benefit to risk ratio that's happening. And so what we know is that patients need to be informed of this uncertainty of benefit and potential for harm. That meaning that the harms they could be diagnosed with the cancer that would not have bothered them in their lifetime. But what we know is few older adults are informed of the risk around mammography or colorectal cancer screening, and many overestimate those decisions. So what's the possible solution? Well, we want adults over 75 and their clinicians to make these individualized decisions, and we want them to think about their overall health, their prior screening history, and their preferences. And decision aids, which Dr. Houston talked about, are designed to help do that. So I'm not going to spend a ton of time other than to say that they are designed to help patients know about available treatments and potential risk and help them participate in the process with their clinicians. What we know is few decision aids are written for patients with low or limited health literacy. And in a recent systematic study, we found that only 12% of studies address the needs of low health literacy or other socially disadvantaged groups. And of those 11 that were reviewed, they had readability scores, none at 8th grade or below, which is where we know most of the American population is. And when they used the PMAT tool, which we'll discuss shortly, which really looks at do folks understand and are they able to act on it? What we know is that 10 out of the 11 met thresholds for understandability, and only 5 out of 11 met the thresholds for actionability. So they may have been able to understand what was going on, but they didn't know what to do with the information. And so amongst all of the many risk factors there are, I really do want us to focus on older adults and recognize that 6 out of 10 or 60%, 6 out of 10 adults over the age of 65 are affected by limited or low health literacy. And how does that happen? How does it impact? Well, we know older adults experience changes as they age, whether that's cognitive, related to their reduced processing speed or their working memory, whether it's visual or hearing. These are things that impact them, which can contribute to their health literacy levels. So let's talk about developing materials. This is about sort of designing and testing interventions. And so what we know is we have recommendations that say health educational materials, of which I consider decision aids a health education material, are written with principles so that all patients can benefit. So if we write those, if we design these materials, if we design these shared decision-making activities in such a way that folks with lower health literacy can understand, then we know everybody can understand. And essentially, they're recommending formative research and pilot testing among these recommended strategies. So we're looking at the language, we're looking at how we're organizing the materials, we're looking at the structure of the materials, and we're doing this in collaboration and with feedback from older adults. And 2 components really are asking older adults sort of questions using the teach-back method. If, excuse me, one second, using the teach-back method and asking folks to repeat the information. So lessons learned, I'm going to start with the lessons learned and then I'm going to go into some of the details. What I've learned in taking existing decision aids, a mammography screening one and a colorectal cancer screening one that I'm working on right now, is what we've learned is it's important to include the target population. So we're including older adults to get their feedback in the design and implementation of the decision aids that I'll talk about. And simultaneously, we're trying to figure out how to determine how to use medical and non-medical professionals to help ensure that these older adults have the materials that they need. If we do this, then we know that all populations will benefit in some way, shape, or form. So let's talk about 2 examples, the mammography example, a mammography screening decision aid example, and the colorectal cancer screening decision aid. So we know about sort of the guidelines, as Dr. Houston talked about, around women at 40 through 75. We also know that at 75 and above, we need to be engaging in shared decision-making. And so really what we did is we took an existing mammography screening by Dr. Mara Schomburg and really tried to understand how to change it for older women at risk for low health literacy. And so what happened? We did a qualitative process where we did structured interviews. We used the think aloud method, and what we found, what they said to us is the language was too advanced. They did not understand how to interpret the pictographs. There were no racial and ethnic representation happening. There were so many words on the page, and they did not understand the tables. They thought it was too long. They really didn't understand what continuing or discontinuing, which was the wording that we used, a mammogram meant. And they had difficulty understanding what it meant to discuss their thoughts with their doctors. So many of them in that study, and even in my current study, are often say, wait, you want us to talk to our doctor about this? And I say, if you're interested in talking with your doctor, absolutely. And so what did we do? So we took that original decision aid, we shortened it from 11 to 8 pages. We eliminated all of the pictographs. We converted the information to a table format, created way more white space, added more pictures, added some explanations around this idea of stopping mammograms in a doctor's recommendations. We also made some significant word changes. Some of them were, instead of using the word risk, we used the word downsize. Instead of saying getting mammograms, we said having a mammogram. Instead of overdiagnosis, which a lot of people really struggled with, we said just laid there, which seemed to make a difference. And so as part of that, we also did an overall assessment using SMOG, PMAT, and the PMOS HARC, the 3 measures to really get a sense of what a document looks like from a health literacy perspective. And essentially SMOG is about readability, and the PMAT is about understandability and actionability, and the PMOS really assesses for the document complexity, particularly around tables. And so what we learned with this particular, with the breast cancer screening decision aid, is that we had a reading grade level of 9th grade, we had understandability at 87%, we were very happy, we had actionability at 100%, and we had a PMOS ICAR score of 5, which suggested very low complexity in that population's grades of grade levels 4 to less than 8 years could understand the materials. And so now quickly with colorectal cancer screening, which is the current study that we're working on, I put all 3 images here to say where we started. So the one to my far left, making a decision about colon cancer with the white couple beneath, was the first title. It was sort of the beginning of the decision aid. Then we shifted after some initial feedback to the middle one with the picture of the colon in the middle, the colon in there. And then we moved to the third, which is where we are today, and we're getting some feedback. And why did we do this change? Because the feedback was around racial and ethnic identity. The research, as you'll see in a few minutes, they felt like that was sterile. They wanted something that exemplified what we were doing. So a similar process, we've interviewed 30 men and women between the ages of 75 and 85. This is phase 1. They had to respond to a validated question as well as have educational level to quote unquote qualify to be at risk with limited or low health literacy. It's ongoing. We are in phase 2 where we've interviewed 21 men and women to date, 4 clinicians, and we'll be surveying 10 clinicians. But what happened in phase 1 is, again, the language is too advanced. They said that sentences were too long and too complex. They didn't understand it. Again, the racial and ethnic backgrounds were needed. And then it felt very sterile. There was this all white background. They wanted something a little bit more exciting because they said, this is not an easy topic, Tam. So let's make it easy for us to understand and read. And in short, to date, we've changed the decision aid from 20 to 9 pages. We've changed words like stool to poop, of which they completely resonates with them. We've added no screening as an option. And so when we think about colorectal cancer screening, there's colonoscopy, there are stool cards, and then the other option is no screening based on sort of your values and your preferences. And then we also added a life expectancy scale to really help them understand what was going on with their health. And again, we did a health literacy assessment. We have a reading grade level at 9, which suggests we still have some more work to do, as well as understandability at 75%, actionability at 83%, and a PMOS ICAR score at 3. So we're happy with sort of where it is, but I think we probably have some more to do, and we still have some testing going on to understand what other changes need to happen. And so we did do testing with the mammography screening. And what we found out is that for the women who we talked to before they went to see their primary care physician, We had them take a look at the decision aid, and then we talked to them after they saw their primary care physician. And what we know is that it affected the knowledge for sure. And so we saw a significant difference and a significant increase from what we're calling pre-test to post-test in terms of the knowledge of the benefits and the harms. And we know that the majority of women indicated that the decision aid was helpful. What we know thus far with the colorectal cancer screening findings from our qualitative analysis is that there is a lack of understanding of age considerations, and there is a lack of understanding of health implications. Why shouldn't I do it is often a message that I get. And yet they're finding it very helpful because this population often says there doesn't seem to be things designed with us in mind, which is very powerful for me to think about. So as we wrap up and we think about sort of this idea of designing and testing, I want us to be thinking about the fact that particularly with older men and women, how do we make it empowering? How do we frame messages so that they feel like these older adults feel like they can use information in a way that helps them? How do we make it self-directed, not us as the researchers or the clinicians? How do we help them learn new information in a variety of ways? How do we make it solution-oriented? We know tons of information. We need to change that information so that it's clear and quick and short and concise so that we can get them to their desired goals. And ultimately, really considering the targeted populations and these overall health literacy assessments as we go forward in some of our work. Thank you.
Thank you, Dr. Cadet. And I'd like to thank you for speaking so explicitly about how you've evaluated your tool using literacy and readability metrics. And so what value did each of these provide as you were kind of iterating your tool, and how did they guide your decision-making about adapting the tools that you talked about today?
So I think that, so often I completely value the participants and their experiences. And yet I know that some of them can be saying, oh, yes, I understand it, and not necessarily want to say, no, actually, I don't understand it. I don't know what you're talking about. And so what we're able to do is, if we sort of start with, I did the literacy assessment before we started, and then we do it again sort of midway to see if we made it, and the changes we made have actually made a difference. And if they haven't made it just different, then we can ask them targeted questions of the participants as we're going forward to be able to continue making decisions. So we know in the colorectal cancer screening, the actionability, understandability are not close to where it needs to be. So in this next round, that's what we're doing. We're sort of focusing on, so tell us what would help more, really to get their feedback, because ultimately we want them to use it.
Great. Thank you so much.
Thank you.
And so in the interest of time, we're going to move towards our next speaker. I will remind everyone in the audience, please feel free to put questions in the chat or the Q&A. We have 2 more presentations, and then we are going to have a lot of time for discussion. So we welcome questions as we go as well. So next up, we have Dr. Aisha Langford, who's going to talk about health literacy considerations for cancer clinical trial communications and informed consent across the lifespan. Dr. Langford is an assistant professor in the NYU Grossman School of Medicine's Department of Population Health. Her work addresses how health communication can improve individual decision-making and reduce population health disparities for conditions or behaviors that lead to preventable morbidity and mortality. She currently co-directs the NYU Clinical and Translational Science Institute's Recruitment and Retention Core, where she provides consultations to study teams on ways to enhance recruitment and retention across various clinical trials. And so I will welcome Dr. Langford.
Thank you. I'm glad to be here, and I'm just going to share my screen. All right. Okay, can you see it okay? Perfect. All right, so I'm very excited to be with you all today, and I'm going to be talking broadly about health literacy considerations for cancer clinical trial communications and informed consent across the lifespan. Okay, so there are several definitions of health literacy. I actually, for the purposes of this talk, am going to be using the Healthy People 2030, and their definition of health literacy or personal health literacy is the degree to which individuals have the ability to find, understand, and use information and services to inform health-related decisions and actions for themselves and others. So just keep that definition in the backdrop as I'm talking. This picture here on the screen is a general model of clinical trial participation that I had published in the Journal of Health Communication a few months ago. And this conceptual model was actually included in a special supplement about vaccine clinical trials, but it has implications for other types of trials, including cancer clinical trials. I will not go over every single bullet in this box or in this conceptual model because there are a lot of them. But I did want to bring everyone's attention to when you're thinking about designing a clinical trial or health research study, you really want to pay attention to the patient characteristics of your target population very, very early on. And that includes health literacy considerations, but also languages spoken and health beliefs and customs. And the other box that I like to bring, especially investigators' attention to, are the clinical trial characteristics and protocol. So many times when I'm doing consultation, a team will say, we're having trouble getting racial and ethnic minorities or this type of people or this group. And a lot of times, unfortunately, the protocol is so burdensome to patients that people either can't do it or they don't want to do it. So we really need to be paying time and attention to that very early in the process, and hopefully including patient feedback so that you're getting a gut check that what you're proposing to do will actually be palatable to cancer patients or whatever group you're trying to reach out to. Another thing to keep in mind is that cancer clinical trials are really diverse in the type of trials that are done, phases of trials, and target populations. So for example, I tend to be more in the area of chronic disease prevention and control and lifestyle interventions, but they're in the cancer space. There are also clinical trials that are looking at different medications or combination of medications. There are increasingly more investigations into potential cancer vaccines, but there are also genetic studies, surgical studies, and studies that are really focused on family units. And all of those have implications with regard to how you communicate, how decisions are made, and what you need to think about with regard to health literacy. And another thing to think about is that, especially in cancer, there are different phases of trials. So if you're trying to reach out or explain a phase 1 trial, which tends to be fewer people very early in the cancer clinical trial process, there may be only 50 or less than 100 people in that type of trial. There tend to be first in humans, versus a phase 3 where there are a lot more cancer patients across the country and you have more evidence. That has implications for, again, health literacy and how you explain the purpose of the trial to participants. So now I'm going to just take a moment or two to talk about a paper that I had the pleasure and privilege of writing up when I was a postdoc with colleagues who actually developed a plain language decision support tool to support cancer clinical trial decision making. And this project was actually done in Florida. And this tool was designed for Black and Hispanic cancer patients. And it went through the development process, really had 3 main components. And the first component, or phase 1, was really information collection, and qualitative interviews were conducted with 45 cancer patients. 15 were English-speaking Black cancer patients, 15 were English-speaking Hispanic cancer patients, and 15 were Spanish-speaking Hispanic cancer patients. They also did a very thorough literature review and a telephone survey of over 1,100 cancer patients in Florida that helped inform the content for the tool. Phase 2 was actually content generation. And so taking all of that information from phase 1, they actually created the content and the layout of the web-based decision support tool. And then in phase 3, it was really user testing with about 10 cancer survivors to give feedback on the layout and understandability of the web-based decision support tool. And some of the key takeaways that overall patients really appreciated the tool and understood it. Some of the feedback from the debrief interviews were that Cancer patients liked hearing about the investigative team, but they really wanted to know if cancer survivors and cancer patients were involved in the development. They also had suggestions that more attention be given to how potential harms of being in a cancer clinical trial was explained. And then also they wanted more information about the informed consent process, and that might help reduce some concerns about people being guinea pigs. And then finally, there was some confusion about understandability of the idea of a placebo and what uh, a placebo is and what that means in the context of cancer clinical trials. So that was some of the feedback there. But overall, it was well received by both Black and Hispanic cancer survivors. I also had the privilege of working with colleagues at the University of Michigan Cancer Center and School of Public Health and colleagues at the National Cancer Center during my dissertation research. And this paper appeared in Cancer in 2013. The primary purpose of this analysis was really to look at potential racial and ethnic differences in cancer clinical trial enrollment, refusal, ineligibility, and reasons for decline among patients that were seen at community cancer centers. And broadly, there was really no racial and ethnic differences in enrollment or refusal or reasons for decline. However, a secondary analysis that we did was looking at reading level score of the informed consent documents. And somewhat surprisingly and counterintuitively, we found that a higher grade level score on the informed consents was actually associated with lower refusal rates. And again, that's a little bit counterintuitive. It is possible that we had maybe more educated cancer patients in our particular sample, and maybe the higher grade level score was not a barrier, but that was a surprising and counterintuitive finding. Another surprising finding was that consent page length of greater or equal than 20 pages was actually associated with lower odds of saying that they had no desire to participate in research as the reason for decline. I do have some thoughts about that as well. That may be a little bit less surprising because depending on how you use font and white space on an informed consent document and images, you can have greater pages, but that doesn't necessarily mean that more page number is going to be overwhelming in terms of information. There have also been some really interesting papers published in the last decade or so. One of them that I thought was very interesting was this one by Burks et al., which was published in Oncology Nursing Forum in last year. And they did qualitative interviews with 20 participants who were considering participation in a phase 2 clinical trial for early stage breast cancer. And the goal of the qualitative interviews was really to understand how patients perceived and understood the informed consent process. And in general, they found that women who had lower health literacy levels were more likely to really defer to their healthcare provider about decision-making for enrolling into a clinical trial. And those who had lower levels of health literacy also reported feeling confident enough in their provider to kind of have somewhat of a deferral in terms of decision making. So that was interesting. So we found that in other studies as well, that lower health literacy patients tend to rely a little bit more heavily on provider recommendation with regard to enrollment. Another interesting study that was done by Krieger et al. And published in 2016 was looking at different strategies for explaining randomization on informed consent documents. And in that particular study, they did a post-test only experimental design with 500 cancer patients. And those cancer patients were randomly assigned to one of 3 message conditions. One message condition was plain language. Another message condition used a gambling metaphor, which explained randomization as like a flip of a coin. And then there was also something that they called a benign metaphor, in which they explained randomization in the context of, like in pregnancy, the likelihood of either having a male or a female child. And what they found was that those who had lower health literacy better understood the benign explanation that used pregnancy or the chance of having a male or female child, that actually outperformed the other message frames or messaging, which was very interesting with regard to understanding randomization. And then finally, Kim and Kim did a study of 150 participants who were either randomized to receive a standard informed consent for a cancer clinical trial, or what they call a simplified informed consent for a cancer clinical trial. And the simplified informed consent included short sentences, plain language, pictures, and bullet points. And in summary, the participants who received the simplified informed consent document actually had better comprehension and understanding of the cancer clinical trial, which is probably not surprising. I also wanted to include this Cochrane meta-analysis or systematic review that was published actually in 2014. So sometimes I have study teams say, well, should we just make everything audio visual? And there is some promise for that, but in this particular systematic review, they actually evaluated 16 different studies that met their criteria. And what they found, and there was data from about 1,800 participants, and what they found was that although there are trends that audiovisual presentation of informed consent information can potentially be helpful for knowledge, it was not overwhelming that this is the best strategy, or that it was basically unclear that these methods outperform all other methods. And almost to my last slide, I just wanted to mention that there are also health literacy considerations across the lifespan. So many of you may work with children and families. So in the context of a pediatric cancer clinical trial, children have to assent or at least demonstrate some willingness to be in the trial. So that raises interesting ideas about what does health literacy and understanding mean in like a 10-year-old who needs to give assent to be in a cancer clinical trial. And then on the other end, we know for older adults, especially older adults of color, they tend to be more likely to live in multi-generational households, which means the family structure may be helpful with regard to decision making. And then also older adults of color in this country tend to sometimes have lower educational attainment and income. And then finally, specifically for Hispanic and Asian seniors and elders, we may need to pay more attention about limited English proficiency and what that means in the context of cancer clinical trial decision making. So a few lessons learned are really to think about grade level readability, use plain language. I would say for all of us to just challenge our assumptions. So a lot of times when I give talks about racial and ethnic minorities in clinical trials, sometimes people will assume that people are mistrustful or don't want to be in it. And one of the biggest barriers is that people are never actually explicitly asked. So let's just make sure we're not stereotyping folks. To also pay attention to design features like white space and bullets, and then provide communications training for your staff so you can always practice how they're consenting your patients before they are doing it in real time, and then using the teach back method. And then a few emerging questions that I think are still to be realized are how to best explain randomization, how can cancer centers really at the systems level support health literacy, how do we handle uncertainty, which is a problem across health conditions, including cancer in general, but with a cancer clinical trial, there's no guarantee, and you're doing a trial because you don't quite know an answer to something. And so what is the impact of that additional uncertainty on patients? And then how, if at all, should we be using audiovisual supports for improving informed consent? So thank you for your time, and I look forward to our discussion.
Thank you, Dr. Langford. So thank you for that great overview of the literature, and I really liked your lessons learned. And notice that, many of these strategies kind of rely on individuals or small teams to implement. And they may have, ultimately less control over some aspects of trial communications. So can you just take a minute and discuss how organizations like trial sponsors or cancer centers, as you mentioned, might prioritize health literacy to remove the responsibility that gets placed on these individual teams to carry out these activities?
So one of the strategies that I've seen is really to have templates designed either by the trial sponsor or maybe at like a hub kind of area, so that the ideas about plain language and understandability are already done, and then the sites can actually just tweak it and do their branding, so then you don't have to start over every single time with designing a flyer. And I will also say that we have been working increasingly closer with our communications and marketing team at NYU, which is very helpful because some teams, end up doing clip art, or they're not really mindful of design features that actually can be very off-putting and counterproductive when you're trying to do recruitment at a broad level. So that's another strategy that we've done. And we also have a patient education team that can review materials in advance. So that's helpful as well.
Great, thank you. Those are great ideas. So we're going to shift to our last speaker today, Dr. Katrina Ellis. She's going to speak about family-focused information needs and processing during and after cancer treatment. Dr. Ellis is an assistant professor at the School of Social Work at the University of Michigan. Her research focuses on family management of chronic health conditions and its implications for the design and implementation of health interventions, cancer control and survivorship, and addressing racial and ethnic disparities in health. An overarching goal of her research is to support the health of families facing multiple coexisting illnesses with a specific focus on Black Americans. So go ahead, Dr. Ellis.
Great, can you see my screen? Perfect. Well, thank you for that introduction. It's a pleasure to speak with you all today. I'll be speaking about information needs and processing during and after cancer treatment from a family-focused perspective. I'll begin my presentation by talking about why it's important to consider health literacy with a family and caregiver lens. And I'll use a conceptual model that has been developed, as well as quotes from interviews I've been conducting with families to help us better understand cancer caregiver health literacy. And I'll highlight some key components of cancer caregiver health literacy during treatment and survivorship phases, particularly among adults with cancer, and end with implications for this work. So after an individual is diagnosed with cancer, their family may participate in many components of their care. This includes helping to find health information, participating in decision-making, as well as navigating care. And all of these activities and many other fall under the umbrella of caregiving. And while the literature often discusses a primary caregiver, we can think about caregivers a bit more broadly. There may be multiple individuals who step in to provide assistance. And I also use the term family broadly to include chosen family as well as friends. And while research has shown that caregivers often have little preparation or support for their role, and cancer is an unexpected illness that can catch individuals and families off guard. So there's a lot to learn and process in a short amount of time. Research has shown that lower health literacy among caregivers is associated with more difficulty assisting patients with care communication and navigation, which are two common ways caregivers are asked to support patients. It's also been associated with lower patient quality of life. So I'll use as a guide for my presentation a conceptual model developed by Ewan and colleagues. And the purpose of this model is to describe key elements of cancer caregiver health literacy. The model was developed with caregivers, patients, providers, and policymakers. And in this model, cancer caregiver health literacy is conceptualized as multidimensional and operating on multiple levels, including individual, family, healthcare system, and community levels. And the key dimensions in this model, or the themes they identified, include access to information, understanding information, relationships with healthcare providers, relationships with care recipients, support systems, and managing challenges of caregiving. I'm currently conducting a pilot study funded by the Robo Cancer Center at the University of Michigan called Facing Forward. And as part of this study, we're interviewing Black Americans who have completed treatment for early stage breast or colorectal cancer in the past 5 years, as well as a supportive family member who they identify. And we're conducting both individual and joint interviews with about 20 dyads. From these individuals, we're learning about various factors that influence their health and well-being after cancer treatment. And because this is a family-focused study, we're also learning about the health of their family members and the ways in which the cancer survivor and the family member both give and receive support. And our ultimate goal is to use this information to better support Black families after treatment ends. And the data we've collected thus far really highlights the importance of attention to health literacy among families and caregivers. So I'll be sharing some quotes from the interviews that align with the conceptual model I presented. The first theme I'll discuss from the model is access to information. So this includes the caregiver having the motivation and capacity to find information to help the care recipient. What we see in the literature is that caregivers desire to be informed and prepared for helping the person with cancer navigate the healthcare system and understand what's happening with medical treatments. Families may access or receive information from many different sources. So the care team, people outside the care team, books, the internet, other media. And this can be incredibly overwhelming, especially when they are unsure of what sources are reputable or how the information applies specifically to their diagnosis or treatment experience. It can be really helpful when information is targeted specifically for caregivers as their target audience and written from their perspective and with them in mind. Caregivers may also look for information to complement care. For example, the first quote I'll share comes from a husband of a woman who went through cancer treatment. And during his interview, he talked about using the internet to find information. He said, "We changed our diet a whole lot when she was going through. You have to do a lot of reading and just research on the web. You can find a lot of stuff on YouTube depending on the things you're looking for. You can type up what you have in mind and then you look for something for that. You've got to put your focus on that and pray about it. You've got to pray about it because the Lord got you to it. And without prayer, you won't get anything. If you don't put the Lord first, and if you don't put the Lord first, and he'll send you to what you need." So he went on to discuss some dietary changes that he and his wife incorporated during her treatment and how they've kept up with those changes after she's finished treatment. He discussed how it's benefited their health, and he talked a lot about their faith and how he felt that played an important role in their experience, specifically being able to figure out what was best to do with regards to their health and find the necessary information. The second component from the model I will discuss is understanding information, specifically the need for caregivers to understand who is a part of the care team and the types of services the patient will receive. Caregivers desire to understand what will happen with the cancer and its treatment and what type of assistance they should expect to provide day to day and also in the future. This component also includes the caregiver's capacity to organize and appraise information. Some research suggests that symptom management can be compromised when patients and caregivers are not fully prepared to understand how to manage symptoms or side effects of treatment. We've also seen racial disparities in symptom management in some of the literature. This research has pointed to ways in which care systems engage families in different ways and may inequitably provide information to help families manage the challenges of care. The next quote I'd like to share comes from a caregiver who was not only supporting her husband through cancer treatment, but was also providing care to her mother at that time. She stated, "My mom was hospitalized for breathing issues she was having, and I just do the research about that type of stuff. They just get overwhelmed sometimes, or they don't know where to look to find the information. So I'll be the one to look at it and then say, look, here's what this is, or what I saw, or what I found." And it just breaks it down for them a bit easier. What we see is that it's not uncommon for cancer caregivers to be engaged in multiple caregiving roles. And this caregiver describes attending to the emotional needs of others who feel overwhelmed with their inability to provide information. And caregivers may be the ones to fill in the gaps. This caregiver did seem confident in her ability to provide this type of support, and caregivers who have more experience in a caregiving role may be better able to address some issues. But this is a potential additional level of burden, especially especially when caregivers are supporting multiple family members. The conceptual model also draws attention to relationships with healthcare providers as a critical component of cancer caregiver health literacy. Both caregivers and patients may have varying degrees of comfort and capacity to talk with and ask questions of providers. This could be related to internal factors like anxiety or external factors like time pressures during the clinical encounter that might limit the time spent with patients and families. Family members often help facilitate communications between patients and the medical team. They may introduce topics and appointments, clarify questions, or provide additional information to the providers. They often will listen and take notes, simplify information for patients, or even help to resolve issues with patient-provider communications. Some caregivers and family members serve as a point of contact for others, so other friends or family members, and patients often receive help from caregivers to be more comfortable in communicating with providers. So as an example of this last point, we saw this in an interview with a cancer caregiver daughter who was a source of support for her mother during and after cancer treatment. She said, "I'll ask questions and ask her how she's feeling. There will be times when she has appointments that she doesn't tell anyone else about, but she'll tell me. So I'm very aware of what's going on. So I let her talk about it. So if it is a fear there for her, she's able to comfortably talk about it and not be questioned. And then I can know what I can do to support her. Maybe some research on what it is she has questions about, things like that, or helping her say, well, maybe we should ask about this. I can't be there, but maybe we should ask this question because that's bothering you." And in this example, we see the daughter talking about giving her mother the space to talk about her feelings and concerns, and also providing support to her mother by helping her clarify questions she has and prepare to talk with providers about those questions. And that clarity can be really helpful for providers to better understand the mother's needs and which could positively influence the treatment provided. The last dimension of the model I will discuss is related to how caregivers manage the challenges of caregiving. This includes the caregiver's ability to care for their own health, and it also entails recognizing the official role that caregivers have and paying attention to their attitudes about stepping into that role willingly or sometimes not. Taking the model a step further, we can also think about concurrent family health challenges, also known as family comorbidity. And this refers to the health challenges that are happening within the family during and after treatment, and understanding how those concurrent challenges could influence their attention to supporting each other and overall health and disease management. This quote comes from a mother who supported her son through cancer treatment. She was asked to reflect on her health during the time of her son's treatment compared to now when her son's treatment was over. And she stated, "Well, I think that's part of my problem with my blood pressure and even with some parts of diabetes. Because of the fact I really just didn't even think about myself as far as trying to take care of myself. I really didn't. I was just kind of like, okay, this is my baby." So I think that's where a lot of my health issues had come. And I just let stuff go. I really did. And I know now when I look back on it and think about it, I probably could have did something different or did something better, but I didn't at the time. We often think about the long-term effects of cancer treatment for patients, but we can also consider the ways in which cancer can influence the health of caregivers and families after treatment ends. And in this case, the mother attributed her current health issues to her lack of self-care during her son's treatment. And during her interview and that of her sons, we also heard about the concurrent health challenges of the family after treatment and how they supported one another in managing those concerns. I'll end with a few implications for this work. First, I think the UN model does do a nice job of underscoring how important it is to consider health literacy from the standpoint of families and caregivers and the supportive role they play. But there is a need for more intentional, active involvement of families as partners in care. This could include more caregiver assessments in cancer care, which are not routinely done. And these assessments could include a measure of health literacy, in addition to some common things that are measured, including caregiver health and feelings of burden. An example measure that might be useful is the Health Literacy of Caregivers Scale Cancer, which was developed by UN and aligns with the conceptual model that they created. We can also think about assisting families in discussing their expectations and desire for communication, information sharing, and caregiver involvement. A resource that might be useful in that area is the Ottawa Personal Decision Guide for Two, which can help families clarify how they would like to make health decisions and who should be involved. And this information could be shared with the care team. And then lastly, a family-centered approach to health literacy during treatment and survivorship would recognize that care systems often have a lot of expectations about the support that families and caregivers will be able to provide. So it's really critical to support caregiver health literacy because of the active and vital role that we know they play in patient care. I'd like to acknowledge my research team and funding from the Local Cancer Center and also the families who are participating in the Facing Forward study. Thank you.
Thank you, Dr. Ellis. So I think we can often fall into this trap of thinking more proximately about patient health literacy and then less about care partners, which your talk so nicely highlights is really a critical component in managing cancer. So what one recommendation would you make to researchers and/or practitioners who want to be inclusive of families and care partners in projects that are aiming to address health literacy?
Yeah, thank you. I think one thing that projects could do is look for parallel ways to support health literacy in families. So we could think about tailoring the content of current interventions to the supportive role that families and caregivers play, and thinking about the lens through which they will be processing the information and trying to make sense of it. They want to do what's best for their loved one, and they're often managing a lot of information and emotions in their efforts to do so. And we can think about also this approach in three ways. So we could think about, of course, what does the patient need? What does the family or caregiver need? And then what does the family unit need in order to work cooperatively in ways that support their health and well-being? And how does health literacy fit into that?
Thank you. So I'd like to just loop back and thank everyone for the excellent presentations. I think we've highlighted a lot of different issues that have come up in these interventions and areas of work across the cancer continuum. But I think a common theme that's, an undercurrent in all of this is how hard decision-making and uncertainty can be for patients, regardless of their level of health literacy. And so maybe there was a question in the chat that came up around particularly the two talks on decision aids, and they should be done, with in conjunction with clinicians. But we also heard from some of these studies that people get overwhelmed by having to bring these things up with their clinicians. And so how do we balance those tensions and maybe think about interventions that prepare and empower patients to be active care partners? And how do all of you think about that in your work?
So I think it's two things. So I think it's good to clarify or just highlight. So patient decision aids kind of in spirit are really meant to be for the individual, for the patient often, but not exclusively, at least in research context, they're actually given to the patients before visits with the idea that they will read through the information, hopefully all of it, but that they will read it and do values clarification exercises and at least have some background information. So they're coming to the medical encounter, hopefully informed and with some maybe idea of what they'd like to do. And then from there, hopefully that will enhance a shared decision or kind of a better patient-provider communication process. So I think obviously clinicians are really important, but I think sometimes what clinicians report is like really critical for patients to know can be very different than what patients want to know. So a lot of times patients will put more emphasis on quality of life and functional like activity, like, can I walk or do my life the way that I want to? Whereas clinicians, understandably so, tend to be very fixated on blood work and, did we get the tumor out, which all of those things are important. But I just want to mention that. And I will also say that there's growing discussion about kind of what types of supports are helpful before an encounter, during an encounter, and after an encounter. It's not a one-time thing. And so, for example, some people have said maybe like a one-page kind of visual or a flip card or something may be more helpful in a medical encounter because you have limited time, but maybe the patient decision aids or some type of after visit plain language summary might be helpful post visit. So just those are just some things to think about.
Thank you, Dr. Langford. I completely agree. The only thing that I would just add is this idea of, because I think I am on the side that decision aids really are certainly should happen between the clinician and the patient, but it's really, at least in my experience in my research, the patients are just hungry for some information that is understandable for them. And then on the other hand, is there a non-medical provider? So, I'm interested in sort of the supports before, during, and after. So whether it's before or maybe after the clinical encounter, do you have, when they're called a lay health worker or a community health worker, a navigator of some sort? And I know there are some studies out there where they've sort of done that, which then sort of helps this process. So it's not this one time only. And perhaps it's not just cancer screening, but it's other chronic illnesses that folks have.
I definitely concur with what you both said. And I think that's such an important point, Dr. Langford, that you mentioned, that these are topics to be revisited. And that's something that definitely came out of the work that we were doing, and how patients are, as Dr. Cadet said, craving this information that they can actually understand and apply. So one of the features that we had that I was really wrestling with and thought we'd probably throw out because we wanted to reduce the number of patients or pages in our decision aid was a questions for your provider, questions to ask your doctor. And so we included in that a few different topics that had come up in our decision or in our focus groups. And then also some conversations about cost, which are really challenging, but the field is moving into a direction to start providing a little bit more information about costs, which poses another challenge for the clinical encounter. So oftentimes physicians and our nurses do not know what the costs associated with many procedures are. So how can we also provide some of the real-time cost information for providers when we're using some of these tools, and especially in the clinical encounter?
I'm sorry, don't mean to be over talking, but if I can add one more thought, I think the financial toxicity is really important. And I think the idea of however we're doing patient decision aids or whatever conversations we're having, particularly with screening, but also with treatment. But with screening, it's not like a one-time thing. If you're doing a screening, you are potentially committing to other things down the road if you find a negative finding, or like with lung cancer screening or any screening, it's not helpful to do at one time. And so I think for screening and treatment, it's really helpful to kind of give patients kind of the full picture without overwhelming, to say, okay, here's the route. If you do A, there's a potential for B, C, D, E, F, or whatever. And so I know I had to make a decision about one of my animals way back. And, I did the first thing, but they were like, well, the next thing would be this. But then after that, it would be like a $15,000 surgery, which I knew I wasn't going to do. But having them say, okay, this is basically, if you kind of do this test, this is like the arc of the decision. That was helpful. And I think there's more conversation of really, not just, oh, let's get you in for your mammogram, but really to say, okay, here's kind of like the broad scope, so you can put it all in context to decide, do you want to take that first step? Because if you're not going to do the next step after that, it doesn't really make sense. And maybe that, talking about financial toxicity, you might be mad that, wow, I don't know, wasted $1,000 out of pocket to get a fancy mammogram if I know I'm not going to do anything else down the road because of my values and preferences, or maybe I'm just a minimalist and don't want to do anything. So that's really important, to really kind of give folks a down the road broad idea of what that whole decision-making arc would encompass, including cost.
Well, and I think to your point, like screening is really a longitudinal endeavor, right? But it's not really posed in a clinical encounter necessarily as a longitudinal endeavor. It's like, do this test or don't do this test. And but it's really, the utility comes from the longitudinal monitoring. And I think that's not always made clear from the outset, or that's not the focus of how we talk about it in clinical encounters. So, we're talking about decision-making here today. So I thought we'd talk a little bit about the International Patient Decision Aid Standards, which just were updated. And I know many of you were involved in the paper on health literacy, which will be presented, I think, tomorrow as well. But this review, as Dr. Cadet noticed, that only 12% of studies on decision aids have included populations that were socially disadvantaged or had limited health literacy. And so, from your vantage, what designs or strategies are needed to be able to develop, to show that tools that are developed are, addressing population needs, especially those populations who need decision support the most, and or ensuring that our tools are promoting equity?
Okay, well, I can jump in. I was on that wonderful paper with Tamara and Ashley. So I think it's important, kind of back to recruitment and retention, to make sure that patients are asked to participate, because many people, the research is really clear that many patients, when they're eligible and actually asked, will participate. So I think the first step is to say, okay, if we have representation in our decision aid studies, we'll know when, if at all, do we need to tailor those decision aids. Sometimes you may not need to tailor. You might find, okay, it works equally well for groups A, B, C, and D. And then it's also, I think, important to see if there's any unintended consequences of the information that we include. So I did an analysis of a decision aid that was used in veterans to look at decision-making around early stage prostate cancer. And we found that responses actually changed preferences. The low plain language decision aid actually changed preferences of white men with prostate cancer, but it did not change the preferences of Black men who had early stage prostate cancer, which was interesting because active surveillance was an option, but the Black men actually said that they preferred more aggressive treatment. And one of the things that we included in the discussion was that we may be inadvertently, you always see these things, Black men are more likely to get prostate cancer early and more aggressive prostate cancer. And it's good. I mean, epidemiologically, that is correct. But if we're constantly saying that, are we like maybe priming or alarming people? And you're like, oh my gosh, I'm a Black man, I'm going to die early, I'm going to get aggressive cancer. And then when you have the choice of active surveillance or radiation or surgery, and they're all equally good choices for you, and you really, really just want to watch and wait and do active surveillance, but like, every other day they're, scaring you that you're going to die early or whatever, like, are people as a defense mechanism or whatever choosing more aggressive treatment because they're scared, or because they think that they're getting things withheld from them because of historic, abuse and oversight and not getting good care decades before. And so it was just an interesting finding. So, we could be thinking that we're being helpful and having unintended effects too of how we're framing information for racial and ethnic populations and maybe, other, groups by income, et cetera. So that's just another caveat, which is why it's important to have inclusion in these studies to be able to tease apart those things.
And I'll just go ahead. Ashley, do you want? Oh, and all that I'll add is to just to piggyback a little bit on Aisha's comment, is this idea of recruiting and retention is hard. It's hard in a lot of different ways because you've got to go looking for sort of people, and then you have to sort of say, okay, so does this validated question, how confident are you in filling out your forms? And people say, I'm very confident. And then you're going through the process with them and it's not. And I know there's some literature around sort of the pride and the stigma of being limited or low health literacy. And so I think there's this issue, how do we sort of break through that? Is that because we're going to, I've been sort of wrestling with this and sort of thinking about, is it okay to sort of have both those, the brief health literacy scale plus the educational level, recognizing that for some folks, the educational quality, particularly when you think about older adults, is not the same for different populations. And so an older adult with a high school degree who happens to be white might look very different than an older adult with a high school degree who happens to be Black, just for a host of reasons historically. And so I think that you have to make these concerted efforts. I have done a lot of work where I am going to community-based organizations and working, and it's a lot of work. And yet the reward when people say, you thought about us, is like overwhelming and overwhelmingly powerful. And I see Cindy Brock said use universal precautions, absolutely.
I think these considerations are also really important as we're thinking about implementation in the future. So really moving that implementation question up, and when we're doing the formative work and thinking about, okay, well, who are our priority populations? Who are we trying to work with and use these tools with? And bringing them in when you're starting to have these questions and engaging them. And it's a lot of work, and boots on the ground, going to these community organizations and really engaging them throughout all the phases of your research. But I think that it is really important to not get to the end of this process and you have this tool and then no one can use it because for this reason or that, not relevant for this population, too much technology to be delivered in another setting. And that's why we have adaptation frameworks and ways that we can modify these. But if you're involving those stakeholders in the very beginning and designing for that implementation process and final product, I think that can be very important in the outcome of your research.
And I want to add, I think it's important, in addition to racial and ethnic diversity, to also think about like geographic diversity. So, I'm an African-American woman. I grew up in the San Francisco Bay Area. I live in New York City. I've always lived in urban areas. I may or may not be similar to another African-American woman who grew up in rural Louisiana. And that has implications also, not just for how people find information, use information, but there's two excellent researchers on here with backgrounds in social work. When you think about social support and resources that you have available to you, that a lot of times is tied to income, but sometimes it's tied to where you live and what you have access to and what your family structure is used to. Like for some people, they might be like, I'm not going to some random support group at a cancer center with some stranger I don't know. But if it was a group in my church or, with my senior citizens club down, the cultural, I think, context and the local customs of the group are really important. And sometimes, that might change by geographic location, just practically how easy it is to get someplace or not. But, what people perceive as what types of social supports are most helpful to them. And it's not always what the academic medical center provides. Sometimes it is, but it's not always that way.
I was just also going to say, I definitely agree with all of the comments related to making sure that we're involving populations in the work that we're doing kind of from A to Z. And I think another thing we can think about with that is also finding ways to compensate individuals for their time and expertise. We often ask a lot and get quite a bit out of the work that we're able to do in collaboration with communities. And so finding ways to compensate them monetarily or in other ways, I think is a way to increase equity and also to show the partnership that we value with those groups.
I 100% agree, Dr. Ellis. And I think organizations and, some large organizations have work to do on how to make that easier for researchers, like how to make structures that allow us to engage and pay community members easily, and removing some of the barriers to being able to do that is really important, because I know, in the past, I fought some uphill battles around how to bring on patients as partners and not compensate them in a research context. So as somebody mentioned, Cindy has been advocating in our chat for universal precautions, which is very much appreciated. And we wanted to get to that topic. So I think now's a good time to transition there and thinking about, have any of your organizations, really implemented the universal precautions toolkit and approach, or what experience do you have with that, clinically or in research? And how do you think about incorporating those principles into your own work?
So I don't know if NYU has like officially said we are using the Universal Precautions Toolkit. I do know that there is a big effort. We do have like I said, a patient education materials group and also like a patient experience group, and they give really good feedback around, basic things like, plain language and signage and, what can we do as an institution, or like when you walk into the hospital, is it obvious where you need to go, which seems very simplistic, but, signage and things like that. So, and our marketing team, interestingly enough, our marketing and communications team, when someone's creating a flyer or some kind of communication that's going to go out, I guess, in mass, they are thinking about, did the patient education experience or the materials team look at it? And then when we have stuff web-based, considerations like, is it optimized for people with like visual and hearing impairments? And, can you do the readability, the reader, I don't know what you say, you have to have it set up in the text in a certain way so that the reader softwares can do it. So in an informal way, we are at least thinking about that at an organizational level.
Any other thoughts on universal precautions?
I would agree. I don't know kind of the overarching for the whole institution. This is a great reminder to kind of dig into that a little bit more and get a better sense of what the overall approach is, and to see how we can kind of support some of the more navigation, communication, direct to patient information. One of the things that I was thinking of, kind of an ancillary benefit of COVID, is I know that it's so challenging to be on Zoom all the time, but I've noticed that we've been able to engage with a variety of populations, and thinking of geographic diversity and having this type of engagement. And I know this is moving a little bit away from universal precautions, but I'm thinking about ways in which we can have ASL interpreters, or having other types of ways to engage populations that may be concerned about how to participate in medical research, and having these chat features and these different opportunities to be engaging in a variety of populations. So just wanted to put a plug in. I know Zoom has pros and cons for sure. And no one wants to stare at a computer screen for longer than they have to, but using some of the technology to be able to engage in not only researchers, but other populations.
Yeah, and just to add on to that, I'm so glad we have an ASL interpreter here. And I gave a talk in May about diversity, inclusion, and research, and there was someone on there. Her name was closed captioner Sherry, and I didn't know like these people like existed, but you know how like you can, I don't know, do the auto transcription on YouTube or whatever, and she was doing the transcription in real time, and she was saying the good thing about certified closed captioners in real time is that people can read it in real time and not have to wait till it gets posted, 5 weeks later on YouTube, but that also some of the auto transcribing things are not always accurate. And I mean, a lot of them are okay, but they don't always get the nuances. And so that is that's a type of person who, yes, for folks who have, hearing challenges or whatever, having that closed captioning in real time with the professional, and not really kind of just saying, oh, well, we'll just use whatever, tool on YouTube or other thing later. I think that's another way to be inclusive of more communities.
Yeah, and even if individuals don't have hearing impairment, but having the transcript, so if someone is, unable to listen to something, or their job demand, various circumstances that they may be in, where that format is just better for them. So definitely agree.
And for me, that's an example of universal precautions, because we're making it available to everybody, and certainly people who are challenged, but folks who aren't even challenged necessarily in that area. And I think it really is sort of that idea of, how do we design stuff? How do we think about all kinds of providers and all kinds of patients? I agree with you, absolutely, Aisha. Rural versus urban, very, very different populations, maybe the same racial or ethnic background. But if we're intentionally, and I'm all about intention, if we are intentionally trying to do something, if we're intentionally trying to make a difference in the work that we're doing, then we're going to be thinking about how do we do this? So yes, it's targeted maybe to folks who are with limited low health literacy, but folks with higher health literacy for in that moment in time. There is a moment in time where they may experience a low health literacy level. They get it too. And that way everybody benefits.
Thank you, Dr. Cadet. So we are at time. We had one more quick question in the chat that we can do by a show of hands before we sign off. So Cindy asked if any of us are involved in training providers in health literacy and shared decision-making strategies.
Yeah, definitely.
Nice. So crossing the research practical divide. So I just want to wrap up and say thank you everybody for joining us today. I think this has been a great conversation just to think about how we're all, trying to implement many of these health literacy tools across the cancer care continuum. And I hope to see others across the conference. And please feel free to engage with us after the fact if you have follow-up questions. Thank you, everyone.
Thanks so
Thank
much.
you. Have a
Bye.
good day.
Thank you.
Bye-bye.
Dr. Gunn.